Short stature is caused by a variety of etiologies, and an early and correct diagnosis is essential because children have a limited time to reach their growth potential with treatment before fusion of the physes. The growth hormone insulin-like growth factor 1 axis, otherwise known as the GH-IGF-I axis, is the principal endocrine system regulating linear growth in children via the activity of growth hormone and IGF-1. Deficiency in IGF-1 results in disruption of normal growth due to the inability of IGF-1 to mediate the growth-promoting activity of growth hormone, leading to short stature. When there is sufficient secretion of growth hormone, but an inadequate IGF-1 production or functional IGF-1 deficiency, then short stature is categorized as severe primary IGF-1 deficiency. A diagnosis of severe primary IGF-1 deficiency is made when a child's height is a standard deviation score of -3 or lower and their basal IGF-1 concentration is a standard deviation score of -3 or lower in the US, or below the 2.5th percentile for age and gender in Europe, and their growth hormone concentrations are within the normal range or are elevated. The classical form of severe primary IGF-1 deficiency is Laron syndrome. In addition to having proportional short stature, these patients may exhibit a number of unique clinical features, such as characteristic midfacial hyperplasia, frontal bossing, truncal obesity, acromicria, and a high-pitched voice. Patients may also present with underdeveloped muscles, small genitalia, and delayed puberty and hypoglycemia. However, a significant number of patients may have a milder, non-classical form of primary IGF-1 deficiency and may or may not have more subtle features. The general assessment of a patient with short stature may include a review of the patient's growth history and medical history, physical examination, and general laboratory tests. An endocrine investigation should be conducted to assess the growth hormone IGF-1 axis to ensure appropriate diagnosis. A growth hormone stimulation test is required to distinguish severe primary IGF-1 deficiency from growth hormone deficiency. Assessment should exclude low IGF-1 resulting from acquired conditions with growth hormone insensitivity, such as malnutrition, type 1 diabetes, or inflammation. Additional tests, such as an IGF-1 generation test and measurement of growth hormone binding protein, may further strengthen the clinical diagnosis, but molecular genetic analysis of candidate genes, if available, will ultimately confirm the diagnosis. Diagnosis of severe primary IGF-1 deficiency requires severe short stature, low serum IGF-1 and normal or increased growth hormone secretion, as well as lack of other pathology in the general workup of short stature. An early and correct diagnosis is essential to allow children to achieve their full growth potential with appropriate treatment.